Hello, I'm Catalina Zara. I'm an assistant professor of anesthesiology with the University of Pittsburgh School of Medicine, and we are going to talk about anesthesia for laparoscopic surgery. I have no disclosures to make related to this presentation. Laparoscopic surgery has been with us now for more than 4 decades. Started in the 1970s with the gynecologic surgery. Has been proven to have significant and multiple benefits for our patients. Less pain, less trauma, shorter hospital stay, faster recovery compared to open surgery. But it does come with significant pathophysiologic changes, and this is what we're going to be trying to highlight today and see how we can best deal with that. And those pathophysiologic changes include creation of pneumoperitoneum, which is the intraperitoneal insufflation of carbon dioxide, significant increase in the intra-abdominal pressure and sometimes intrathoracic pressure. And also we have to deal with significant patient positioning problems, which can affect our hemodynamics and respiratory physiology. The respiratory changes tend to be most important and most frequently encountered in laparoscopic surgery. We can see significant reduction in the thoracopulmonary compliance, sometimes by up to 50%, decrease in the functional residual capacity, and increase the risk of atelectasis due to the increased intra-abdominal pressure, and increase in the partial pressure of carbon dioxide. Usually we'll reach a plateau after about 20 or 30 minutes after insufflation, but sometimes we can see significant increases after that, which are many times attributed to subcutaneous emphysema. The increase in the partial pressure of carbon dioxide happens due to increased absorption due to the CO2 insufflation, but sometimes ventilatory changes can contribute in patients with pulmonary pathology. The partial pressure of carbon dioxide should correlate with the end tidal carbon dioxide in healthy patients and assuming that no acute intraoperative events occur, but significant gradients can develop in patients with pulmonary pathology or when acute intraoperative events occur. Respiratory complications can be divided in 3 or 4 more main categories. The more common one would be subcutaneous emphysema, which is typically suggested by an increase in the end tidal CO2 after the initial plateau in the first 20 to 30 minutes of insufflation. And that's mainly determined by the carbon dioxide pressure insufflation. And sometimes we have to either stop or significantly decrease the insufflation pressure in order to allow for the subcutaneous emphysema to resolve. Pneumothorax or pneumomediastinum can be potentially life-threatening, leading to desaturation, significant increase in airway pressure, or significant decrease in the cardiac output. And that happens usually in a lower esophageal procedure due to the embryonic remnants or the communication channel that are connecting the thoracic cavity with the abdominal cavity. So when insufflation occurs and the intra-abdominal pressure increases, that can be transmitted in the thoracic cavity. Endobronchial intubation can occur when the cephalad displacement of the diaphragm will also move the carina cephalad and allow the endotracheal tube to slide down, usually the right mainstem bronchus. And last but not least, gas embolism, which is a rare complication but most dangerous and occurs when insufflation of carbon dioxide occurs in the intravascular space. The reason we use carbon dioxide for laparoscopy and insufflation is because it's high solubility compared to other gases. That means it can be eliminated and absorbed very quickly and increases the margin of safety. However, depending on the amount of carbon dioxide that's insufflated, the size of the bubbles, and the rate of intravascular entry, it can still produce a fatal gas embolism despite the fact that carbon dioxide is otherwise considered safe. The diagnosis, a high index of suspicion is required to diagnose gas embolism. The signs can be fairly nonspecific, such as tachycardia and hypotension, but also can be more specific, such as hearing a mill-wheel murmur in the precordial area, significant decrease in the end tidal CO2, also aspiration of gas if a central line is already present. Treatment includes immediate stop of the insufflation and release of the pneumoperitoneum, placing the patient with the head down with in the left lateral decubitus, the so-called Durand position, to minimize the amount of gas that passes through the right ventricle in the pulmonary artery. Immediately discontinue the nitrous oxide in case that's being used. Hyperventilate the patient to increase the CO2 elimination. Provide 100% oxygen if hypoxemia occurs. And cardiopulmonary resuscitated if needed, which may include the placement of a central line to aspirate gas if the gas embolism is significant. And the next slide shows a nice algorithm that helps us differentiate between the various respiratory complications that can occur during laparoscopy based on the either increase or decrease in the end tidal CO2, but also the presence of desaturation, increased airway pressure, hyperresonance, and the presence of swelling and crepitus allows us to differentiate between gas embolism, pneumothorax, subcutaneous emphysema, or endobronchial intubation. Hemodynamic changes can be significant during laparoscopy. The main one would be a decrease in the cardiac output due to both venous pooling and inferior vena cava compression that can be attenuated by fluid preload, but also an increase in arterial pressure and increase in the vascular resistance, which is not a reflex response to a decrease in the cardiac output as we might expect, but is actually produced by various mechanical and neurohumoral factors such as stimulation of peritoneal receptors and release of catecholamines and vasopressin. There are significant changes related to patient position in order to obtain good exposure. Many times those patients can be positioned in steep Trendelenburg position, meaning with the head down, or steep reverse Trendelenburg position with the head up. Cardiovascular system can be affected with a significant increase in the intraocular pressure that can worsen the glaucoma in patients who are placed head down for long periods of time. If the patient is placed with the head up, it can significantly decrease the cardiac output or the mean arterial pressure due to the blood pooling in the lower extremity. Head down position can be deleterious to respiratory system due to the decreased compliance and the functional residual capacity, although patients with head up benefit at least from the respiratory standpoint. Nerve injury are always a concern for patients undergoing laparoscopic surgery. Brachial plexus stretching and injury can occur in a head down position, but also peroneal nerve injury can occur in lithotomy position. Due to the significant side effects that carbon dioxide insufflation can pose, other alternatives have been proposed, such as using inert gases like helium and argon. Will avoid the increase in the partial pressure of carbon dioxide associated with CO2 insufflation. However, the effects of pneumoperitoneum remain, and the low solubility of those gases decreases the margin of safety if gas embolism occurs. Also, gasless laparoscopy can be employed, but despite the benefit that this avoids all the effects of carbon dioxide use, it can make the exposure for the patients, for the surgeons, rather difficult and increase the difficulty of the surgical procedure. Laparoscopy has numerous benefits, whether it reduces the stress response, reduces the amount of trauma, peritoneal trauma, and the bowel manipulation, reduces the incidence of postoperative ileus, and decreases the length of hospital stay. The postoperative pain is better in laparoscopic patients compared to open incision patients. It can still be significant, but less than with an open incision. It is multifactorial. Visceral pain tends to be a more important component of it than parietal pain that's encountered in patients with open procedures, but also referred pain such as shoulder pain from diaphragmatic irritation or from residual pneumoperitoneum. Pulmonary dysfunction tends to be more significant as the procedure is closer to the thoracic cavity and the diaphragm. So the upper abdominal procedures tend to have more respiratory dysfunction compared to the lower abdominal or gynecologic procedures. Post-operative nausea and vomiting, it is a frequent complication and can delay the discharge and prolong the hospital stay. It is exacerbated by opiates and possibly by nitrous oxide. Its incidence is reduced with antiemetic therapy, use of intravenous anesthetics over inhalational anesthetics such as propofol, but also drainage of gastric contents and fluid administration. Complications of laparoscopy tend to be different between different categories of laparoscopies. When we talk about gynecologic procedures, the complications tend to be more frequently related to insufflation per se and the trocar introduction, whereas in gastrointestinal surgery, they're related more to the procedure itself. And if the complication is significant enough, such as intestinal injury or vascular complication, it can lead to conversion to an open laparotomy. Bariatric procedures are commonly performed within the last decade or so, are commonly performed in laparoscopic fashion. There are two main categories of bariatric procedures: restrictive, meaning reducing the size of the stomach, or malabsorptive, such as gastric bypass, where the metabolism or the absorption of food is impaired. We're not going to discuss this in great detail since this is covered in another section, but we should all be familiar with morbid obesity and associated conditions, whether it's cardiovascular, pulmonary, or metabolic, but especially airway management for patients for gastric banding and stapling. And one common misconception is that patients that are very heavy with high BMI, body mass index, are likely to have a difficult airway. In reality, there is really no direct correlation between the patient's weight and the difficulty intubation. What is much more important, though, and correlates much better with that, is the Mallampati score, or the neck circumference. The abundance of pretracheal soft tissue or the poor positioning will be more important in managing the airway than the actual patient's weight. Gastric banding, performed laparoscopically, minimally invasive. It involves placing a band around the stomach to reduce the stomach size. It's favored because it's good results and the fact that there is no permanent alteration of the gastric anatomy. Hiatal hernia repair is another common procedure performed in laparoscopic fashion. There are two types of hernia: type 1 sliding type and the type 2 paraesophageal. In the first situation, the gastroesophageal junction actually slides in the thoracic cavity, whereas in the second one, the paraesophageal, just a portion of the stomach herniates into the chest, but the gastroesophageal junction remains in place. Those patients have a significant incidence of acid reflux, which puts them at risk for aspiration pneumonia, but also the type 2 hernia patients are at risk for gastric volvulus. The repair of hiatal hernia can be done either through an abdominal or thoracic approach, but it may not be enough to prevent the acid reflux, in which case additional procedures such as a Nissen fundoplication may be needed to prevent the acid reflux. When we evaluate patients for laparoscopy in the preoperative period, we should be focusing on specific conditions that can be significantly exacerbated by the increase in the intra-abdominal pressure and the associated hemodynamic changes. And those are patients with increased intracranial pressure, patients with severe left ventricular dysfunction, patients with significant hypovolemia or renal failure, in which cases alternatives such as an open laparotomy or a gasless laparoscopy may be employed in order to minimize the hemodynamic changes. Positioning, we will be very careful with those patients both at the beginning of the surgery in order to position them properly to prevent nerve injuries, as we discussed previously, brachial plexus or peroneal nerve injury, but also perform a slow, progressive, careful tilting of the operating room table during the operation in order to minimize the respiratory and the cardiovascular changes. As far as monitoring is concerned, an arterial line should be placed anytime there is expectation of a significant gradient between the partial pressure of the carbon dioxide and the end tidal CO2. Arterial line allowing the direct measurement of PaCO2. Although a central venous pressure line or a pulmonary artery catheter can be used, the measurements will be greatly affected by the positioning or the increase in the intrathoracic pressures, so those numbers may not be very useful for management. General, local, or regional anesthesia can be employed for laparoscopic procedure. Most of the times a general anesthetic is preferred because it secures the airway and allows for controlled ventilation and control of the end tidal CO2, especially in more invasive procedures or longer procedures. Sometimes the avoidance of general anesthesia is important in select patients in which regional anesthesia may be employed, but we should keep in mind that a very high level may be necessary, T4, and maybe even higher than that, and it can be uncomfortable for the patient. In conclusion, laparoscopy offers many benefits: less trauma, less pain, fast recovery, shorter hospital stays. It does come with significant intraoperative respiratory and hemodynamic changes we should all be familiar with, and it's very important because laparoscopy is being used in a widespread fashion, and more sophisticated newer application, including robotic surgery. We're going to make management of laparoscopic surgery more and more important.